Welcome, welcome, everyone. We're so glad to have you here. We've had a lot of interest in this. Very interesting topic. The Mothers for Mental Health Care Reform have published 3 podcasts so far, and this is our first ambitious live panel discussion. Mothers for Mental Health Care Reform are not doing any fundraising. We don't have a petition for you to sign today, but we are interested in working with other partners on these types of topics. We're so pleased today to have the guidance of Nicole Waldron helping us out this afternoon as our host. Take it away, Nicole.
Well, Iris, thank you so much for having me here and inviting me to be a part of this awesome day, this awesome discussion. It's a tough discussion, but we're going to get through it. For those of you who don't know me, I am a mental health advocate, and I also have lived experience with a loved one with a serious mental illness. Today's curated conversation is brought to you by Mothers for Mental Health Care Reform. Now, if you don't know about Mothers for Mental Health Care Reform, it is an organization that advocates for improvements for people living with serious disorders such as schizophrenia, bipolar, and psychosis. Let me just share with you some stats regarding mental health. So according to the Canadian Mental Health Association, about 1% of Canadians will experience bipolar disorder, and another 1% will experience schizophrenia. Mental illnesses are caused by a complex interplay of many factors. These illnesses are treatable, and people living with these illnesses can recover well and carry on regular life once they receive the right treatment. For this reason, we campaign for improvements in regulations. People with serious mental health disorders deserve access to best practices in assessment, treatment, and rehabilitation, with families included in their care at all stages of their process. Today, we will provide you with some information and points of discussion, which we know you will talk about, and we hope you talk about with your family and friends. Some you may not have even known how to approach. Now, the thing is, we know if you have a physical illness and you go to the hospital, you'll be assessed. You'll have blood tests, they'll possibly do x-rays, they'll do a whole plethora of examinations for you to figure out why you are unwell. Once completed, the doctor provides you with a prescription or referral to a specialist, or sometimes they leave you with being assessed and treated on your way to recovery. You normally have a recovery, some sort of plan. Now, come with me here on a journey. Imagine you are very ill with one of the mental illnesses like schizophrenia, bipolar disorder, concurrent disorders, and you end up having to be living on the street for a number of years. You have no shelter, no food, or no way to generate an income. Your caregivers have been trying their very best to help you. They offer to take you to the hospital or a healthcare provider. But you don't believe you're sick. You think you're perfectly fine, despite the fact that you're in danger of freezing outside, probably to the end result of not being here anymore, in a homeless situation. And until you believe you are unwell, you won't consent to being treated. So no one has authority to help you, and no one in authority will help you. This scenario of denial happens also to someone who can be living at home alone or with loved ones. As such, it is likely that they have something that is called, I know this word trips me up all the time because it's one of these big words that you really never hear. And it's called anosognosia. Always trips me up. See why? And we're going to delve into this a little more as we go into the conversation. We know that even when someone with a severe mental illness is taken to hospital, they often have to wait for hours in the emergency department to see a doctor. Often they can be sent away without a prescription, without a plan or referral. And especially if they are deemed not imminent danger to themselves or to anyone else. Can anyone identify? If I could see you all on the screen, I'm sure I would probably have many hands up with people identifying that experience. When leaving the hospital, they often will be without further assessment or treatment or recovery plan. So some more statistics before we get into the conversation. Statistics highlight that 50% of individuals with schizophrenia and 40% with bipolar have symptoms that show this lack of insight. Some psychiatrists believe the numbers are even higher, estimating that 57% to 98% of such people have it. Unfortunately, one of the key challenges is that navigating the mental health system is very frustrating. We are very aware that anyone can get psychosis. Actually, no one is immune. Some people with severe mental illnesses may lack insight completely. And this is the focus of our conversation today. Now, we've put questions to our panel, we've had conversations with them, and we got questions from you, and we took that input and we put together curated this discussion for you. And so we're going to discuss what is anosognosia. Why can't I say that word today? I say it all the time. What does anosognosia mean? And we're not going to use that word too much because it's just too much of a trippy word today on this first snowstorm in Toronto. If you are zooming in from Toronto, it's our first snow day. And I want you to know that this lack of insight is not a conscious decision to deny, to minimize, or refuse facts, which may seem to other people who are reluctant to take medications for their diabetes, their alcoholism, etc., when they acknowledge their preferences may not be in their own best interests. Some people with psychosis lack the connection and do remain unable to appreciate that their perceptions, delusions are not really true. So though that today's topic is complicated within a larger subject of serious mental disorders, we have 4 great people that have agreed and said yes, from the medical field, from the legal field, and with lived experience. So joining us from Kingston, Ontario, hope the weather is better over there, Dr. Dan De Jesus, who has focused his practice on schizophrenia since 2010. Then we have lawyer Lisa Fieldstein, who is a lawyer who has a touch of focus on healthcare crisis issues. Lisa had noticed that patients' families did not even know where to turn. And she understands our rights. And we know as caregivers, sometimes we don't understand our rights. And families have been left feeling powerless and confused. So Lisa has taken on a mission to help struggling families to navigate the system since 2013. We are so honored to have you, Lisa, as well. Joining us with lived experience, we are pleased to have our special guest, Jesse B., who will discuss his journey. And also Jackie, a mom who has had several journeys through the mental health system with family members. Now, if we were in person, you would be able to give a round of applause. They would be able to feel your love and feel your joy in the place. So welcome then in. I'm going to ask our amazing tech person to get everybody on the screen for us so that we can see Lisa, Jesse, myself, and Dr. Dan. Dr. Dan, welcome, welcome, welcome.
Thank you. Thank you for invitation, for being here. Such an important topic. Thank you so much.
You're one of our heroes because you get it. You so get it. Now, this word that I cannot say today for love nor money. How do you pronounce it?
It's a fancy word, like you said.
Yes. So anosognosia.
You got it.
What is this amazing word that leaves us baffled? I just say it's lack of insight. What is it?
Yeah, I think you got it, Nicole. It's lack of insight or lack of illness awareness. They're basically the same thing, right? So anosognosia comes from the Greek, like many of our words or terms in the medical field, basically meaning lack of awareness or lack of ability to see illness. Nosos, illness. Anos means lack of, right? So meaning the person has a specific deficit or illness or symptoms and is simply, unfortunately, unable to see or to be aware of that symptom of illness.
See, I like your history buff. You went into the Greek. Yeah, I love it. I'm already loving you, Dr. Dan. My first time meeting Dr. Dan, and I'm totally enamored because not many people would go down and break the Greek down. Now, we will have our loved ones show up in the emergency room, and sometimes I think even the police, the medical professionals may not understand they have this lack of insight. How does it really show up in the emergency room? And what can we do?
Yes, very good question, because that is, I would say, as you indicated, Nicole, the majority of people experiencing acute psychotic symptoms or an acute psychotic episode will most likely be unaware or lack insight into those symptoms, right? So it will show up as, you know, the person, as you said, was brought by police because they were clearly unwell, let's say on the streets, yelling, or tormented by hallucinations, voices, or delusions that people, let's say, are out to hurt them. And then they will be taken to the emergency, and the emergency team, the physician or someone else, will try to talk to them to see what's really going on, what's the issue, and they will say, nothing, doctor, or whoever is talking to them, everything's fine, police pick me up, I don't know why, I think it's unfair that I'm here. It might be, whoever they believe it's against them told them to bring me here for some other um, reason that is not related to having an illness or experiencing psychosis. So they don't believe they need any help, and they will likely refuse any help, including medications, which are still the a very important part of the treatment of psychosis or schizophrenia.
So I want to take you into a next part of it, because they're showing up like this, and we find that sometimes we know this consent and capacity that we have to deal with. And so a loved one goes into the hospital, they don't have the insight, and a family member shows up and wants to talk to the medical team. But this whole thing of permission, you have to give permission. And so, as a doctor, knowing this, what advice could you actually give to clinicians when somebody, or even, nurses and police officers, whether they're on the screen, and we may be able to educate them that my loved one has a lack of insight, or the person that they're seeing has a lack of insight, because we know that when they show up in emergency, depending on the state of the psychosis, they can act quite normal.
Yes.
And people will say, oh, there's nothing wrong. So how can we navigate that in the hospital setting?
Yeah, a few things there. One is the physician is allowed to receive information from a loved one, even without consent of that person. However, the physician is not able to disclose any information because of confidentiality, privacy issues, right? But receiving that information is allowed, it's legal. And often, as you indicated, it's so important, because as you also indicated, oftentimes the person themselves, the patient who presents, may be withdrawing what really happened, not really forthcoming with what's going on, especially for people with multiple presentations or visits to emergency. And of course, it can be very stressful, often
Right.
with contact the police and all that, right? So we often rely on the loved one to tell us really what's been happening in the last few days, or sometimes weeks, or even months, right? I would further say also that it should be the duty of any physician who works at emergency or psychiatric units to always assess a person's capacity to consent to treatment, which has to do with the assessing the person's insight. And however, that is, in my experience, not always done in a timely fashion. Sometimes it takes a little too long, and the person's still suffering from severe symptoms. So that has to be done quickly, and a substitute decision maker should be selected as soon as possible if that's the case.
I love that, and Iris and the team, I hope you're listening, because I think we're building many discussions from just the first part of our question. And even when I'm listening, I think Lisa, I'm going to pull you in soon, because from that legal standpoint, and Lisa, let me just pull you in now before I go back into with Dr. Dan. Because Dr. Dan, you said, the family, the caregiver, and I'm hoping everybody, you have the right to share information. Now, in that first 24 hours, like, you take your loved one, to the hospital, are there any more rights, Lisa, that caregivers may have to get information from? Because I've been told that 24-hour window of, I may call the police and say, you need to come and get them. What do we legally can do to help the staff understand, I need to share with you, my loved one has a lack of insight?
So caregiver itself isn't really an official legal role. And I always find that interesting. The Healthcare Consent Act had these purposes at the beginning of the law. And actually, I'll read out just a little phrase. One of the purposes is to ensure a significant role for support of family members when a person lacks the capacity to make a decision about treatment. But what does that actually mean? It doesn't mean that much, except for the one circumstance if a patient is found incapable of making a treatment decision. Then they will have a substitute decision maker. Most of the time that's family. We can go down that path. Most of the time that's family. So that's when there's some room for family members or a particular family member to get involved, is as the substitute decision maker who would be asked to consent or refuse to consent to a proposed treatment. Other than the role of a substitute decision maker, there's not really rights of caregivers, but there is that right. It's not really written necessarily so expressly throughout the Healthcare Consent Act, but absolutely to share information. That's quite essential, because otherwise an individual can and often will mask symptoms, or because of lack of insight don't know they're experiencing symptoms. I can't tell you the number of family members that have told me their loved one acts completely different in the interactions with police or hospital, and they can pretend they're fine for a very, very brief moment in time. So family members can and should be sharing information so that physicians can do their job and have collateral information.
I thank you for that, Lisa. And one of the things I'm going to ask everybody to think about is what are the solutions we're going to have to put in place, whether it's that we have to go in and do some education sessions to the importance of understanding the lack of insight. Dr. Dan, you spoke about capacity, because the capacity assessment may not be done early enough. And depending on where you are as a caregiver, or if the coming into the emergency room, you're kind of stuck between trying to tell the doctor if they allow you in, and you have to push your way in. So I think one of the things I'm going to say to everyone on the line, you have the right to share information. And that's what we just heard from Dr. Dan and Lisa.
I do have a few slides. So the first slide is just about schizophrenia. I think we spoke about this a little bit earlier during this event. I would highlight on this slide the fact that schizophrenia is by definition a chronic illness. And we all know it's disabling, and also can be progressive, and especially, which leads us to the second and next points there. The more relapses and the more severe the symptoms are becoming, often because the person not getting the treatment they need, the more severe the symptoms may become, and which is also associated with impaired insight or anosognosia. And the concept of anosognosia, again, the person lacks awareness or understanding of the condition they are suffering from. Patients who suffer from more positive symptoms. Positive symptoms are experiences that are added to the normal or average human experience, so to speak. So this refers mostly to delusions and hallucinations, abnormal thoughts, often paranoid thoughts, hallucinations, things such as hearing voices or sounds that no one else can see or hear. And as I just said, seeing, also visual hallucinations are fairly common, followed by olfactory hallucinations, and sometimes even tactile hallucinations, feeling touches on their bodies or parts of the body. And that's associated with homelessness, as Nicole indicated earlier today.
Right.
And the more symptoms one has, often they will need more medication, which sometimes means having more side effects and more medications in general. So this is a slide on the kind of the brain and what it does in different areas of the brain. So the frontal or prefrontal cortex, or the lobes, are more here in the red. Executive functioning, working memory, things like multitasking and working and managing information and all that. Memory, more in green, the hippocampus, which is affected, for example, in Alzheimer's disease, quite popular. The more parietal in red, more a little bit back there, more things like attention, but also processing sounds, which has to do with auditory hallucinations, for example, and visual perception in blue, the back of the brain, the visual cortex. So anosognosia and schizophrenia has been described in almost up to 90% of people suffering from schizophrenia. If you read the studies, it varies greatly, depends on the methodology and all that. But most studies mention between 50 to 90% of patients will suffer from anosognosia, lack of insight, at some point during their life. Again, the concept there, we don't have to repeat that. What's interesting, so to your question, Nicole, what happens in the person's brain to explain that I can explain why they have this issue. Basically, so the short answer would be seems to be a feature of the illness itself. So, right, so just like someone with schizophrenia might suffer from paranoid delusions or thoughts, they often will suffer from anosognosia or lack of insight. It was first identified in people who suffered stroke, and that's back to his name was Babinski, many years ago in 1914, so several years ago. This physician identified that people after a stroke, they were unaware that they now had no more movement or sensation in, let's say, their left arm. They lost the function, but in their minds, they still could move that arm when they clearly couldn't anymore. Wow. Yeah, interesting, right? So that was identified back then, and when they looked at what was wrong in the person's brain, they saw it was a dysfunction in the right side of the middle area here, the parietal cortex. Mm-hmm. And then more recently, then someone figured out quite quickly, which makes sense, that this is similar to people with schizophrenia, for example, because similarly, they have obvious symptoms to most people, including family and loved ones, but they are completely unaware, right? So when they looked at people's brains, they saw something similar. They saw a dysfunction or a imbalance between the hemispheres, the size of the brain. So in those structural imaging studies, when they looked like MRIs, let's say studies, they saw that the right side of the brain, a hemisphere, was smaller, which is here in the fifth bullet. Right. Smaller volumes, so the sizes were smaller, and the activity to counteract that on the left side, it was increased. And so that seems to explain why people suffer from anosognosia in schizophrenia comparing to, for example, stroke.
The bing bing moment. I'm just gonna pause you right here, because this is like the bing bing moment. I'm gonna tell you, people, the brain is an amazing instrument. I think it's the most fragile part of our body. That's my belief. And understanding that mental illness is a brain disease that affects the mind. And if you're hearing Dr. Dan, you're hearing how much the brain is a part of this. So I'm going to encourage you to remember how much the brain is a part of this. So even when you have to think about stigma and even explaining to family members, this piece right here is so significant. Go ahead, Dr. Dan.
On that note, I often say it's like the patient is a victim of their own illness, not only because of the symptoms they suffer, but now they suffer from an illness that doesn't allow them to be aware that they're suffering from that illness and therefore seek and accept treatment.
And it's like that double-edged sword, we think of, as I sit here and I think about it, the lack of insight is actually when somebody is an imminent danger to themselves in one way. And I think that's some of the things that I know frustrates a lot of us when we see someone who has a lack of insight. You worry as a family member that something can happen to them because they're just not aware, because in some ways they're in their own world, and their own world is okay. It's you're the one who's unwell. And so when they go outside, and I think that's some of the stuff we try to communicate to our clinicians, we try to communicate to those in the political field, the legal field, and our family members, that it's a different thing that is happening. And I think this is a really great segue. Lisa, if I can pull you in back into the conversation, from your practice, we know that they say it's no amount of arguing will convince a person who actually lacks insight that they have insight. And in your work, how do you see this showing up? And I know you can't really mention cases, but how do you see this showing up, and probably some of the advice you've had to give to family members and to doctors when they're navigating this lack of insight?
Yeah, and I don't even have to share any specifics. The themes that come through hundreds of times over and over, it's virtually the same in so many types of situations where my clients aren't even trying to convince. By the time they've come to me, they're not trying to convince their loved one. They've done that. They're not going to lawyers as the first order of business. Most people, they don't even think a lawyer has anything to offer. This is a medical problem. So by the time they get to me, they've done everything they can to try and get their loved one help, to encourage them to seek help and be supportive. They've often gone to family support groups. So usually by the time people have come to me, there's a history of the person has gone to the hospital already. Sometimes that's been through police involvement. They've had to call police, which can be pretty devastating, but they felt like there was nothing else they could do, or bystanders or other neighbors have called police, or some people have gone to a justice of the peace to seek a Form 2. And so normally by the time people come to me, there's this pattern of they've been brought to the hospital several times. Sometimes there's been some admission to the hospital, but it's a in and out. They were there for a few weeks, or sometimes they weren't admitted at all. They were there for a few hours. The person masked their symptoms. They behaved as though there was nothing wrong. Out they go. Or they were there for a few days, few weeks, discharged. Often the family has no idea they were discharged. They aren't sure what happened. They aren't sure if there's a diagnosis, if there's treatment. They don't know what happened. So there's very similar things that seem to happen across many, many families. And when there's a lack of insight, if the individual themselves doesn't know that they're unwell, it can be quite important for the family to know so that they can share medical history, make sure their loved one's actually taking the medication, and play that supportive role. But often they're not given an opportunity to. Sometimes because of the law, sometimes other reasons.
Lisa, when you say that, I wonder, is there anything that family members can be equipped with, like documentation from a lawyer like yourself, that they can use, whether it's in the emergency room or when they now even become an outpatient and you have to keep saying, oh, I have consent, oh, I have this, oh, I have this. What can we get?
Mm-hmm.
Is there anything we can get?
Yeah, so definitely there's things that families can do. And the longer someone's kind of navigating the mental health system, that sometimes they learn some of this on their own, but starting to keep notes, having a chronology so that you can share the history on one page, high level, what's maybe the months and year of some really significant events. The diagnosis, sort of the history of the person was formed for 3 weeks at this hospital. So kind of high level information. If they have someone they're seeing in the community, the name and contact information. So kind of having a summary of the big picture. And then when it comes to actually getting somebody treatment, often that means having to get someone hospitalized. The laws are different. Healthcare Consent Act deals with consent to treatment, and the Mental Health Act deals with involuntary status. And yet they often go hand in hand. It's really difficult to get somebody to begin treatment if they're not in a hospital. So often it becomes actually learning more about what's involved with getting somebody hospitalized. Do they even meet the criteria? Where I get involved is advocating for them and communicating in a way that I'm speaking the language of the Mental Health Act. So they take information, they share the information, and I take it and I basically repackage it so that I'm being as helpful as possible to give the physicians what they need to know to decide, is this patient capable or not? Do they meet the criteria under the Mental Health Act? Ultimately, there's only so much I can do. I share the information. It is the discretion of the physician, but the role that I play is like a translator. I'm taking the information, I'm trying to translate it into the language that helps the doctors do their job and synthesize the case really quickly, because they can't read, I assume, 20 pages of history. We need to kind of get to the point of the most significant information that they need that day.
You brought up something, and I know as a caregiver myself, it's sometimes you have the greatest intention to write down stuff for the doctors when they're going into hospital to show that they have a lack of insight or whatever. And I like that you said write down something in a one-page, high level, that we can just say, here, read this, because it also gives that opportunity. You can hand it over without being the person that, because sometimes you're trying not to betray the trust of your loved one, because you're in this precarious position as a caregiver where trust is very valuable at that time. And Lisa, I'm going to give you homework. Is that okay?
Yeah,
If-
absolutely.
okay. I think and I think I'm going to give Dr. Dan that homework as well. I think it would be really great if we had like a few list of points and questions, or points that we can actually put into this one page. I won't even say question. What are the key points and what are the questions we need to ask ourselves as caregivers? And if you can probably put this in when you have a moment, that you can send it to the team, and maybe we can send it out to the people who have attended here today, because I think it would really help as I sit there. What would a one-pager look like over 9 years of an illness? How can I sum that up? And what are the key points I need to give the clinicians that can say, this is when lack of insight is shown. This is when I believe that this is what an imminent danger to this person looks like versus what it looks like to Dan or what it looks like to Lisa, because it looks different to everybody else. So Lisa, I really appreciate that point of putting that one pager together.
Although I will say a long version helps too in the
Yes.
unlikely event someone's pursuing guardianship, more is more. So if someone is inclined to have a long version and they later do end up seeking guardianship, more information will be helpful if they actually keep copies of things and have greater level of detail. But most of the time that won't be required.
And I think is, Iris, another conversation for another day when we start talking about CTOs and the SDMs. That longer version would definitely help, that I can say to the doctor, here is the history. So when you're going to do or put together a Form 3, for instance, and you know that your loved one is going to protest the Form 3 or the Form 5 or the Form 33, whichever form they decide to protest, here's some history, because sometimes you have this blockage, and I see Dr. Dan nodding his head, because doctors don't have the lawyers that they can use, but the patients have the lawyers that they can use. And so if we're dealing with a lack of insight and someone being released prematurely, being equipped, how we equip you as a doctor and the clinicians is key. I'm loving this conversation. Okay,
Yeah.
I'm going to pause on Lisa. Dr. Dan, did you want to throw something in there before I go to Jesse?
No, I was going to just make a comment there, Nicole, to what you and Lisa said. That can make a huge difference, having that information more long-term, especially in we, the forms we use in the Mental Health Act, forms 3 and 4. There's the box A, which is the risk for serious harm, so imminent risk to self, others, or lack of self-care. But however, have the box B criteria, which includes the risk of substantial mental deterioration, which is only applicable for people who are incapable. So having that information, often long-term information, as you said, that the person lacks insight and how that manifests, and previous admissions showing, importantly, showing previous improvement with medication treatments, is really important. If there's no acute imminent risk to self or others, then we can rely on box B and hopefully keep the clients in the hospital and receiving the treatment that they need with the consent of the substance decision maker, of course.
Dr. Dan, if you were in front of me, I would be hugging you right now.
Thank you.
That box B, I think, is a bing bing moment.
It is.
Because you see, I'm seeing some thumbs up on the screen. That box B is a bing bing moment, because so many times, I know I've said it to doctors, you need to talk to me. Because, and if it's been 9 years, 5 years, 12 years, 20 years, somebody is denying, they're getting significantly unwell. And so knowing, because we don't see the form, you guys have the form.
Yes.
And so understanding that we can probably suggest to the doctor, maybe because of the lack of insight, do you think that there is more deterioration happening? Would it be more prudent for you to take box B than take box A and saying he or she is an imminent danger to themselves? That, Dr. Dan, is
I would
priceless.
say I would say that's a great suggestion sometimes. Also, another important thing that makes me think of right now, Nicole, is treatment acceptance is not capacity. Just because a patient is accepting treatment in hospital, antipsychotic medication treatment, that doesn't necessarily mean they are capable, because fairly often, patients accepting treatments for I would say, the wrong reasons, between quotes, just to get out of the hospital as quick as possible. It is stressful. Again, we acknowledge that. Or just because the doctor is saying it might be good for you, but they lack the true appreciation of that decision, right? And then oftentimes the first thing they do when they leave the hospital, they stop the treatment because they were never fully capable to make that decision. which has to do again with forms and all that. So capacity assessment have to be done, and it's an ongoing assessment, sometimes daily or several times a week, right?
Treatment acceptance, people write this down. Treatment acceptance is not capacity. That right there. I feel like we're in school. I feel like there needs to be a part 2 already.
Right.
And even reminding doctors, because, you know, I have a lot of empathy for doctors, and I know when you go to the wards and the emergency department there, you know, the mental system is already challenged, but you guys are moving at a mile a minute. And so the more that we can equip you and not have to do this battle, and we have the information that Lisa suggested, you know, have that one pager, and that kind of stuff is helpful. So, you know, I want to pull Jesse into the conversation. And Jesse, I've listened to your videos. I was just so pulled in listening to you talk, and I learned so much. But I don't think everybody knows how you finally said, you know what, I need help and I need treatment. Can you share briefly a little bit about that? How you had that bing moment with insight?
Nicole, you're doing a great job moderating today, and thank you to everybody who is here today, who have shared and who are working in the background. Yeah, well, I mean, so I have schizophrenia, and actually, we're on the topic of the word being a Greek word. Just a little bit of history about the word schizophrenia. Schizophrenia is a combination of two Greek words, schizo and phrene, which translates into English as split mind, right? But don't get it twisted. Schizophrenia is not split personality disorder or multiple personality disorder. It's a totally different diagnosis. Multiple personality disorder is far more rare than schizophrenia is. And and as you said earlier, yeah, 1% of the population experiences schizophrenia themselves, but it's a far greater number when you look at all the people around them, right? Because when somebody is suffering from schizophrenia, it's not just them; it's everybody around them that is experiencing it. So yeah, I definitely had a lack of insight. I was never raised religiously, but when I became psychotic, I'm sure you're all familiar with the word psychosis, psychotic, a break from reality. I was never raised religiously, but at the age of 21, I started to have religious delusions. I started to hear voices. On the right side, I heard a on the left side, I heard a commanding, destructive male voice that I believe was the devil. And on the right side, I heard a calming, soothing female voice that I believe was the Virgin Mary, right? So I had religious delusions. I was hearing voices. I was having paranoia. And to be diagnosed with schizophrenia, you need to have a cluster of symptoms, a cluster of psychotic symptoms. And that's what I had. And that's why I was diagnosed with schizophrenia. I was first said that it might be drug-induced psychosis because I was doing a lot of drugs. But what happened was I got off all the drugs, wasn't even drinking, and the symptoms persisted. And that's when I was diagnosed with schizophrenia. So when you first experience psychosis, it is so real to you. You know what I'm saying? It's so real. You believe it all with all your heart, 100%. You believe everything in your psychosis, right? So there's a lack of insight, right? Because at times I thought I was Jesus Christ. At times I thought I was a prophet, but I believed it with all my heart, right? And like was said earlier, the individual who has schizophrenia and is experiencing psychosis oftentimes can talk a good game, and that's very bad for treatment. If you go into hospital, you talk a good game, the doc says, you know, they've got it together. This person doesn't have psychosis. They leave, and then they start yelling at the voices on their way out of the hospital, and the doc never sees it, right? So how can you really treat somebody if you don't see the real symptoms? So for a while after I experienced psychosis for the first time, I could talk a good game. You know what I mean? When I needed
Right.
to, I could talk a good game. But what was fortunate in my story was that eventually I got so ill, I couldn't talk a good game anymore, right?
Mm.
So everybody's seen somebody on the streets yelling at nothing, right? What's happening there is they're yelling at the voices they're hearing in their minds, right? That's what you see when somebody's yelling at nothing on the street, they're yelling back at the voices we're hearing. So at when I first started hearing voices, I would reply at a talking tone in my mind. Then, as I got sicker, I would reply in a talking tone out loud. And when I was at my sickest, I would yell back at the voices, right?
Hmm.
So I eventually got so sick that I couldn't talk a good game anymore. And the thing that happened was my dad had a friend who was a doc, right? And he brought him in to talk to me and sit with me and talk to me for a bit. And he came in and he sat with me, and I was like babbling at the time, right? Like I couldn't keep it together anymore.
Right.
And the doc sat with me for about 5 minutes or so and said, yeah, he's probably got schizophrenia, right? So the authorization went in. He filled up, because he was a doc, he was able to fill out a form 1 for me. Filled out the form 1. The cops came to pick me up. I was apprehended, not arrested. Apprehended is for a mental health matter. Arrested is for a
Right.
criminal matter.
Right.
So the cops came. I was apprehended, and I was brought to CAMH, College Street. Used to be called the Clark. I was
Yes.
brought to College Street. Unfortunately, I was so ill that they said, we need to keep this guy, right? So they kept me for 3 months at CAMH while they tried medications on me. And then I was released just before Christmas that year. And then I had another hospitalization for 3 weeks the next year, right? And thankfully, the psychiatrist found the atypical antipsychotic that works for me, the one that I'm still on today. And people ask me like, why are you doing so well? And for me, it's very simple. It breaks down into, and not necessarily in this order, faith, medication,
Right.
family, friend support. That's the simple equation for recovery. Even
And
though it's not a very simple thing to do to be in recovery or stay in recovery, right? But those are the things for me that kept me that keep me well, So
and I remember, Jesse, if I heard correctly, there was a point where that you realized, and correct me if I'm wrong, the voices stopped when you started taking the medication. And that
yes,
was the
yes,
big moment.
yes. So, there's this whole thing about like, is the medication helping? Is it not helping? Do I need to be on it? It was mentioned earlier about somebody like leaving hospital and going off their medication, right? Um, and in the mental health field, we call that revolving door syndrome, where we get on the meds, get well, say, oh, I'm well now, I don't need the meds, go off the meds, get sick, and then go on and off and on and off, right? So, um, sorry, what were you?
So I was asking, just making sure that I understood it right. It was you actually being off of medication, being unwell, and then you went on medication, and then the voices stopped, and that was one of the
Right,
big
right. So
insight.
the way I knew I needed to be on the medication I was on, and this was huge. This was huge insight, was that when I went on the medication I take for like 2 to 3 weeks, the voices disappeared. I stopped hearing voices. And that's when I said and admitted to myself, I have schizophrenia. You know, I've had spiritual experiences. I have faith. I have a belief in God, and I have a like a spiritual life as well. But I know that I have schizophrenia. And for so many people, it's so difficult for them to admit themselves that they have schizophrenia, right? Whether it's because of the stigma, whether it's because of the big bad combination of Greek words, you know what I mean? Like, people don't want to be known to have schizophrenia, or people don't want to admit that they have schizophrenia for various reasons, right?
Yeah. And it totally makes sense. And I think, when you said that, Jesse, it was a bing bing moment for me. And you're gonna hear me saying bing bing a lot. And it was the aha
Yeah, I
moment.
think when you say bing bang, I think about bling bling.
I need some bling in my life. Trust me, I need some bling.
Yeah, yeah.
Um, because it also, makes me think, what questions could we ask our loved ones who are doing unwell? What do
Yes.
you notice the difference when you're well and when you're unwell? Because those are the things we kind of wonder how and when to have those conversations to help them have some insight into, okay, I'm well, I'm not doing so well. And the fact that you were able to recognize when the voices stopped when you had medication, I think that is such a crucial point you made there, Jesse. So I
Yeah.
really
And
thank you for
and
sharing.
yeah, and in terms of, like, like, I don't want to say nagging or anything, that might be a bad word to use, but um the individual who has schizophrenia isn't can't see what you can see as a family member. You know what I'm saying? And I mean, it's good to encourage, it's good to try to make some sense with the person about what they're going through, but it's difficult for the person, right? And the other reason why I'm doing so well is because my parents never left the side of me. Like, they were always there. Like, through my good times and bad times, they were always there. And I would not be where I am today without their support, right? So,
So
what I would say to family members on this in this meeting is to support them through the worst of it. You know what I mean? And to hold in your heart and have hope that there is a future for your loved one. You know, because I was out preaching on this street about Jesus with long hair and a beard, disheveled clothing, and smelling nasty, right? But I was able to recover, and I was able to get through it. And today I still have symptoms, I still deal with stuff, but it's a lot better of an existence than it was then and what it could have been. So
Jesse, that is okay. I'm trying to keep it together here. I'm the host. I'm not supposed to cry right now, but you just gave so much hope right there. And if this question is a hard one for you, let me know. Because even though a question is asked, it doesn't mean it needs to be answered, right?
okay, yeah.
You have the right to say no. And no is a complete, I tell everybody, no is a complete sentence that does not require an explanation. It just means no. Um, now that you've had treatment, and sometimes it was involuntarily that you were by your parents, and I'm so grateful that you can see what your parents have done for you, and you're encouraging us as parents to stick to it.
Yes.
uh,
Or any relationship you have.
or any relationship, whether it's a spouse, whether it's a partner, whether it's a sibling, or even a friend, because sometimes friends are the ones who come up and help. How do you see the importance now of you having that involuntary treatment? Because there's this pushback because you had that lack of insight that, well, we're interfering with your human rights. But we were interfering. Is it a part where it becomes where we're interfering that we're not allowing you to get well? And so this involuntary conversation happens. How do you feel about having been made to have treatment when you didn't think you need to have treatment?
That's funny, Nicole. You say I can say no to that question. I'm not even close to a no on that question. That's a great question. And the answer is, I am in full agreement with what happened to me. I accept it. and I appreciate that that happened, because I don't know where I'd be if that didn't happen, you know? And this is the thing, you know, when you get hospitalized, a lot of people get really angry at their family members for putting them in there. You know, a lot of, you know, and I was quite angry for a while too, before I gained insight into my illness, right? But looking back, like, that's what happened. That was supposed to happen, and I'm glad it happened, because that was part of my recovery. Was that right? So, may take time. It may take time, but your loved one will probably come around and say, "Yeah, that's what needed to happen." You know.
And if they don't come around, just know from what I'm hearing from you, if they don't come around, know that you're doing the best that you can to get them
Yep.
the help they need.
Yep.
And
Yep. Be there
that,
for them. Listen to them. Try not to judge them. I was heard. I heard in the community and working in the community that, you know, when you're dealing with somebody with psychosis, don't go fully along with their delusion, but don't, you know, cut it off and say that could never be possible, type thing. So trying to be as neutral as possible, not too polarized when discussing or talking about delusions or psychosis.
and Jesse, I thank you because you had to try different medications to get to the one that worked for you. And I'm going to ask you one more question. That is, I know it's a quandary for many people. I've heard um the part about the injections, because it's involuntary treatment. Sometimes you may have to put, instead of taking it orally like once a day. Did you
I
ever
am.
have to do the injections? Are you on injections right now?
No, no,
Oh, okay.
I am isn't part of my story.
Okay.
I am isn't part of my story, because I think, what was it? Yeah, when I first got out of hospital, I wanted to live with my parents, so they gave me three things. You take your medication daily, you
Right.
speak to your father civilly, and you have a shower once every 2 days. And those were the conditions, right? And so that's what I did. And, you know, eventually I decided to do all those things by myself. And I'll have you know that now I shower every day.
I just Jesse, you are so amazing. You really are. And I really hope we can have more conversations with you because you're such a gem. Because and I say that because we know how hard it is when you've had a mental illness and you have a mental illness to admit it, one, and then to talk about it publicly too. It's really hard. And as a mom sitting here, you know, you have given me such hope today. And I can see the heads nodding and the faces I see the smiles happening. And so I hope I hope we can be able to have opportunities to share your journey more because and I would say to clinicians, to the politicians, we're going to do a road show, Jesse. Are you ready? Are you ready for the road show, Jesse? I'm ready to take you on the road with me somehow
Hey,
because
with me, it would be a circus, Nicole.
don't worry, we can bring some other things along because I think the politicians and all these different people who don't understand what you just said. My loved ones came alongside me and don't give up. We know that we can get a little belligerent. We can say some bad things. I know I hate you, mom, and so don't
Yeah.
take it personally. Remember, it's the illness. Dr. Dan remembers and says to us, remember the brain, and the brain is changing. It's a neurological thing that's happening with the brain. And at this point, I'm gonna pull in Jackie into the conversation because Jackie, you're a mom and you're listening to Jesse, and you've had the opportunity to hear Lisa and Dr. Dan, and now Jesse sharing his story. Um, and I know we had a little break, so guys, we may go over a little 2:30. Hopefully, we're good. We're going over 2:30 a bit, and we are recording. Uh, when you had to take your loved ones to the ER, Jackie, did you find there were different outcomes at different hospitals with different doctors?
Jesse, just wanted to say thank you. I know Jesse's story because I watched his YouTube. If nobody has done that, watch it. His whole story's on there. Actually posted his story on our Instagram at the very beginning when we started it, just because it was so inspiring. And actually my son's journey, we met Jesse very early on in Eric's journey. So Jesse always inspires me. So if you haven't heard his entire story, I, as a parent, as a caregiver, do so, because it does give you hope. And before I answer your question, Nicole, every single caregiver on this everywhere needs that. We need the hope, right? Because there's many times when you're just in that feel sorry moment. This is not working. What can I do? I'm losing it. You got to watch Jesse's story and what his parents did to keep you going. So thanks for coming on, Jess. You're always inspiring. So your question to me was, for those that know, I'm navigating the system between two family members. So obviously I have a little different experiences with both. Both have the same diagnosis. So yes, I find actually the entire system is luck. And as many of you caregivers will know, luck when you go to the justice of the peace, if they're going to give you the form, if you've given your story enough that they actually will give you the form, then you get them to the police. Well, then the police have to come, and hopefully you're lucky that you've got empathetic police officers there, experienced with mental health. Then you get to the ER, and then you're hoping that the ER doctor has some empathy or some compassion or experience, or just he's going to be in a good mood that day and listen to you, so you can get your loved one to at least stay there long enough to see the psychiatrist to give capacity. So there's many times when they get turned away. It's because you just didn't have the right doctor, the right judge, the right justice of the peace, and it shouldn't be that hard, but it is. And if you did get a no, don't give up, because the next justice of the peace, you might just write it a little differently, your story, make it a little more compelling, and you might just get the right justice of the peace. Just don't give up. If the first no, you just got to keep getting them in there, because involuntary treatment saved my son's life. And I will never, ever regret doing it. And it's the only way to get really ill family members help. And this is the biggest obstacle as caregivers we have, is getting them the treatment they need, a bed, a doctor, community support. And yes, it's important to keep the history, but I'll tell you, when I go to the ER and I give them all the history, the doctor will say to you, okay, that was then, but what is now? Why do I need to keep your son today? So you have to have compelling information for today as well. Past is important, but also today, because they have a job to do and they got to fill out that form, and they have to fill out the form. Your story needs to fill the reasoning why that doctor is going to keep your child, even if it's just 72 hours initially. So every step of it is a fight. Every single time you have to get your kid to the hospital or your family member to the hospital. It's a fight every time.
Jackie, how did you navigate when your loved ones had a lack of insight? How did you communicate with your loved ones? I think you said your sons. How did you communicate with them with this? Like, were you able to get them to see they had a lack of insight?
I'm going back many, many years. So initially, obviously, just like most of us, when it first happens, you have a normal child, and then all of a sudden you don't have a normal child. Like, it almost there must have been little signs, but I mean, most of us, because of the age, that could have been hormonal, so we missed them. So yeah, when we finally see that they're not well, they're in psychosis. So yeah, in my sons, I guess initially we did get him to go to the hospital. but he had anosognosia at the time. I said the word. I practiced
Yes,
it.
I
I like
remember.
it initially, and I still remember the caseworker, because you always have to see a caseworker too before you even see the psychiatrist, had told me at that time, and it never resonated really, but it said to me, "You're about to go on a very dark journey." And I mean, I'm a problem solver. So when someone tells me, okay, this is what the problem is, I'm saying, okay, what can I do to solve it? I have to fix it. Let's do something. But as you're navigating the system, we all know that's not as simple when you're dealing with mental health, especially psychosis or schizophrenia. And when he first got that diagnosis, I remember like crying and saying, any diagnosis, but not this one, please. And maybe it was because of stigma, but it was also because I knew the difficulty with this, what his life now is going to be and how difficult. And I guess the grieving part as caregivers and as parents, that, you know, this child that you had all these dreams that weren't going to happen anymore, at least to the initial dreams. Not that they could not recover. I knew they could. I listened to Jesse's story very early on, and I knew there was hope. And that's pretty well, it keeps me going every single day. But the obstacles haven't changed in 16, 17 years. And this is the frustrating part. We need to make changes so caregivers can help their loved ones. I can tell you right now, my son would probably definitely be on the streets, most likely not alive anymore if we did not step in. And it was only because I had a great judge, a great doctor, a caseworker that all aligned at that same moment that he was admitted the first time for a long time, and where he first got his diagnosis. So it's it's hope is the big word. You have to keep it.
Yeah, hope is the big word, and I think that's one of the things of this discussion. And Jackie, so I thank you so much for doing this and being a part of this conversation. And I know we want to get into so much more. I'm going to start winding down, and I want to come back to you, Dr. Dan. And before I do, I wrote down a thought. So I'm going to pause. I'm going to press the pause button. There's one in cyberspace here. And you said something, Jackie, that just came back to mind. Release the guilt. And also, Jesse, you said it too, that keep going. And I think as caregivers, we carry a lot of guilt. And did I miss the signs? And I will be totally transparent. Even 9 years into my journey with my son, I was feeling the guilt. I was like, what is the sign? I sat there, up to last week, because my son was in the hospital over Christmas and over New Year's. And I'm going, what sign did I miss? Did I miss the signs? And I was going back in my remembrance. How did I fail as a mother? And I was going into that failure conversation, because you do feel like a failure, like you've done something wrong. Like I should have caught it. And Jesse, you said something. Jackie, you said it, and I think about it all. When Dr. Dan talks about the brain, it was that reminder. This is a brain disease. This is a brain disease. And because early on, so many people were not equipped to call it a brain disease, it's been thought of, just think it away, and they're just being behavioral problems. And nobody really honed on that the brain is affected. The behavior is affected because something is happening in some part of the brain. For the different illnesses, it's different things. And the fact that you even said, we don't do brain scans. I wish that as soon as a person went into the hospital, there was a brain scan that was done for some of their mental illness. Where are they in their journey? And so this conversation is opening up a whole lot of things. And so when we think about going back to receiving involuntary treatment, Dr. Dan, in your professional opinion, how important do you think this actually needs to occur or not occur? Because I don't know where you sit on the pendulum of it.
I think it's absolutely necessary in many cases, Nicole. Because I was going to say, back to Jackie, conversation with Jackie just a few minutes ago, having hope is very important, but I was going to add having the information is also important. So when she described going to the doctors and the doctors asking, but how are you, how can I help you today? What's happening now that you hope that it will make me keep your son here? So having the information matters there in that situation, for example, because there might not be an imminent risk to the person or someone else, but you may say, for example, but I see my son is getting worse by the month, or every year I see more and more impairments, right? And so simply mention the words, I think he's incapable, lacks insights, and the box B criteria that we spoke about before, for example, might change the whole picture, right? The patient might be kept for treatments not on a box A basis, but on a box B, and then receive the treatment they need. Similarly, now back to your question, for a patient who's incapable and on that basis lacks insight, and on that basis is refusing treatment, often the only option we are left with is involuntary treatment.
Right.
And that is the beauty, the huge benefit of the injectable medications, long-acting injections we have nowadays, because it's not practical and not fair to anyone to, for example, it's not doable to force a person to take oral medication pills. However, an injection can be administered every month in the hospital, for example, even sometimes against the person's will. At least in the beginning, it is very much necessary.
Thank you so much for being so honest and transparent, Dr. Dan. Lisa, when we think about the involuntary treatment and we have all these moral dilemmas and legal dilemmas, what can we do to, deal with the legal aspects of really getting our loved ones the involuntary treatment that they need to have, or that we believe that they need to have to be better?
So in order for someone to be admitted as an involuntary patient, education, understanding the Mental Health Act criteria, and I'm happy to share a resource. We have some information about that. We have like an online courses that people want to do it themselves and go through, but learning what the law is, because often where people are not able to get past some of the barriers is they're sharing information, but it's not the relevant information at that time. Like it's not giving to, like sort of Jackie mentioned, too much history, but not focusing enough on the now, when hospitalization is about the now. Somebody can't be admitted as an involuntary patient for something that happened 4 years ago, and they're perfectly fine now, nor should they be. So understanding enough about the criteria in the Mental Health Act to be helpful and know what examples are relevant. You don't have a lot of time. If you're putting something in writing, it has to be relatively brief. If you have an opportunity to have a conversation, it has to be reasonably brief. So knowing what the law is, so you know which examples help. And that's going to be different for different things. Advocating that someone be found incapable is different than advocating that they be placed on a form. Those are different things. They're actually come from two different statutes. So the more you know, the more you can refine what you're saying and how you're saying it to help advance the goal that you're pushing for.
And would it help if you were an SDM when you have to talk about lack of insight? Or does it not matter?
Well, SDM, in a way, it's an automatic status. It's a patient is found incapable, and then there's a list in the Healthcare Consent Act that tells us who is their SDM, or substitute decision maker. So that the order is actually finding of incapacity, turn to the substitute decision maker. It's not really something that you get in advance. Even if somebody makes a power of attorney for personal care, I have one. My husband's not making my decisions. He's on the sidelines. If I'm found incapable, only then would he have a role to play as my SDM.
So we need to have a whole conversation about SDMs and CTOs and all that great stuff, because that is something that sometimes I find even in the hospitals, they don't even understand navigating the the SDM or the and I'm sometimes I just throw it out there. I am his SDM.
Yeah, I think this is actually a really important point, is they don't know everything at the hospitals. When I started my career, I actually worked for hospitals. And one of the things that I learned was, wow, these big sophisticated organizations, there's too much to know. Nobody knows everything. They don't all know all the laws. And so I would read health records and it said POA, and I'd ask a question. There's no power of attorney. They meant substitute decision maker. Legally, they are similar but different things, but the difference matters. So or I have clients tell me the doctor said they can only admit my loved one if they're suicidal. not true. That's not what the Mental Health Act says. So remembering that these are human beings, they know a lot about medicine or whatever their area is, but they don't know everything, and the laws change. So educating yourself and coming maybe with some humility and you know, respectfully, but remembering that these individuals don't necessarily know all the laws. And sometimes when you're educated and you can share that in an appropriate way, that might be necessary and helpful.
You know, it makes me think that we need to have like the key questions that we normally get asked, or the key encounters that we normally have, so that we are equipped when we go into hospital. Because when we're in crisis as caregivers, we're not remembering all of these great things. And so you're jogging my memory to say, okay, I have this is what you can do. This is what you can do. I have the right to talk to you. You don't have, even though you can't share my information. And so, Lisa, in your professional opinion, knowing that you've been advocating for people for so long as we wind down this conversation, and I notice we'll probably have to have just a whole legal conversation, what do you think needs to change in the mental health care laws for people with serious mental illnesses to get treatment?
Yeah, there's a few things that can change, and then some of it does come back to this education, because far too many of my clients tell me they were turned down, and what they tell me, what they were told, I'm like, that's not what the Mental Health Act says. So some of it's education, some of it's probably resources. It might be some health professionals are making difficult decisions when there's not enough beds. So who are they going to help? One of the changes that would be helpful, because it's a very black and white, easy change, is currently if a patient is found incapable, they can challenge that finding of incapacity at the consent capacity board. Great. We need to have some checks and balances and patient liberty, of course. So they can challenge that at the consent capacity board, have right to a lawyer. But if the consent and capacity board then agrees with the physician and upholds that finding of incapacity, that individual can then bring an appeal to court. And we have numerous issues there with those appeals just sitting, where the lawyer will file the first document and then not push the case forward anymore. Legal aid won't fund it. And so it's just sitting in limbo. So this is one change that groups have been advocating for, because it's low-hanging fruit. There's already multiple layers of patient rights, of rights advisor, legal, consent capacity board, and then a substitute decision maker has to follow the law under the Healthcare Consent Act, which includes following a prior capable wish if the patient had made one that applies. So there's layers and layers of rights. And despite all of that, there's this right to appeal. And as a result, individuals are either being hospitalized for months and months, not getting help, or because they're taking up a bed, or because it's unethical to detain someone who's not being helped. Different people will have different reasons. They're discharged when they actually meet the criteria and they are incapable, but they're discharged. So this is one of the easy changes that we can be making to legislation, is this right to appeal that is interfering with many people's ability to get care right now. So it's less controversial and sort of easier, and the amendment would be quite simple. And some other provinces have already done this. So this is one. I'm happy to share more information if anyone wants to go to, be part of the groups that are trying to change this or look at the legislation, but it's low-hanging fruit, this one.
That is, you're right. It's the low-hanging fruit, and it depends on who it's important to. And when I think about, those who are the powers that be, sometimes, we do know that some people who needed to get their loved ones help, they don't stay here. They either go and get private help and can get a psychiatrist or a psychotherapist that can help them and navigate their loved ones through the system, so they don't actually have to be in the system and experience what most people have to experience in the system. Is there a way, Dr. Dan or Lisa, before we go, is there any way that you think that families can be more involved in the capacity assessments? Is that a possibility?
Yeah, in fact, there was a question a while ago. The question was asking if families are involved in the capacity assessment. My answer would be not directly. The capacity is a personal assessment. The individual has capacity or lacks capacity, so it's the person who's being assessed. However, it weighs into that assessment information or collateral information from the family. In cases such as the ones we discuss here, right? The person is giving all the right answers. Yes, I have this mental illness, and I accept treatment. But when in fact the actions speak more than words, in other words, that person, as soon as they are discharged, they then start refusing treatment and then re-hospitalized again over and over again. And sometimes I say to the board in these hearings that Lisa referred to, the consent and capacity board, that again, actions speak louder than words sometimes. So that's when I think the family can really help providing that history, the information they have about their loved ones. But it's not a direct involvement.
I love that. And thank you, Lisa, for that, sharing that resource. Here's a thought, Lisa. When, and maybe Dr. you might be able to jump in here. So your loved one's been formed. We know they have a lack of insight. The doctor may have put, oh, they're an imminent danger to themselves, but they're not realizing there's more to it. Is there a legal way, Lisa, that a family member can intervene and say, okay, you have there that they are not they're an imminent danger to themselves or to others, but I know it's more than this, and they're about to go to the consent and capacity board, and you're kind of stuck in this lingo because you know it's about to, you know it's not going to win because they have the wrong stuff in there, and your loved one is going to be released. Is there any legal precedent for families to intervene?
So families can be involved in different ways. One way, if it does go to the consent and capacity board, is they can be involved as witnesses. So they can be asked, sometimes they are asked to put something in writing. They can also sometimes be witnesses where they show up and they are asked questions. This now sometimes happens through Zoom, but they can actually be examined by lawyers that are at the hearing. If there are lawyers, physicians often represent themselves, so psychiatrists can self-represent in these hearings. So they can be examined and a witness, it's a legal proceeding, but they can actually share information. They also might have other documentation, text messages or photographs they can share and say, this might be useful evidence, and then speak to that in a hearing. So if they're called as a witness, they can be involved. The consent and capacity board rules allow for individuals to ask to be a party, but that's not always going to be granted. That will be harder to achieve, but to reach out to the psychiatrist and say, I actually support what you're doing here. I agree my loved one should be on a form. I'm willing to be a witness or write something. How can I help you with this case, and offer that assistance?
Yes, thank you so much. And I would ask all of you to think about your last words as I close out here. And I thank everybody for sharing today, and Jesse and Jackie in particular. You've shared your personal stories, and it's not always easy when your personal information is out there for the world to see. We will have a discussion. I definitely know behind the scenes how we're going to share this part of the live, because we went in a little deeper. We went into some private details, and we do try our best to protect our loved ones. And so we're going to make sure everybody is copacetic with everything going live or being shared publicly. We hope that you have gained some valuable information today about insight and what causes it, and how you can equip yourself, because at the end of the day, as loved ones, we have to totally equip ourselves, and that's the reoccurring thing that I kept hearing. And hope and information is key. So Lisa, any last words or anything you want to share?
Yes, actually. Right now is a great time to be advocating to your MPPs. I've been involved with some advocacy over the years, and I've learned there's large chunks of time where they cannot get anything meaningful done when it's an election year or right after an election. So we are in a window of time in this election cycle where change can happen. So write to your MPPs, include people like the Minister of Health. Make your voice heard, share your family story, and if you can, share specific suggestions of it would have been helpful if X existed, whether that's a resource or a change in the law. But now is a time where you actually aren't falling on deaf ears because they can do something based on we're in the election cycle. They need to hear from enough people to know this is popular opinion, that there's enough of the constituents out there that actually care about these issues, versus this is a fringe issue. No one cares. No one's going to vote over it, and might actually have some backlash. So now is actually a great opportunity. I would encourage every single person to be sharing your story with your MPP and Minister of Health, because this is actually a really important window of time to make some changes.
That's good, Lisa, because it's going to make us think, it's going to make us write our stories, it's going to make us be able to help us condense what we need to condense from the 12-page letter to the 2-page letter. This is a good exercise. Lisa, I'm giving you homework. What are the key things we need to make sure and have in those letters? Because our stories are long, our stories are powerful. And you ask a question, and this is one thing I'm going to remind everybody. Lisa just said, it would have been helpful if this had happened for my loved one, ... That's the blank, I think, one of the things that we're filling out. If this had happened, and if you know anyone who has especially lost their loved ones in a traumatic way, whichever way, they could still be on the streets because they're still alive, or they have lost their life. This is the perfect time for them to write and said, if my loved one had this, I could see this could be a different outcome. Dr. Dan, your last words. Well, not your last words, but your closing remarks.
Thank you. Yeah, the sharing what others said. It's so important to be talking about this today. Lack of insight, anosognosia, the tough word, but also the fact that there's hope. The fact that we can make a change, a positive change, by, like Lisa said, sending letters, talking to politicians. I think we, as physicians who do these hearings, we often, fairly often, get kind of frustrated with the consent and capacity board. Sometimes the decisions, you'd be surprised with, patients they deem capable, or they cancel the involuntary status. So having that feedback from the community, from you guys, is so important to, hopefully changing the way these decisions are made, and creating better policies for our clients, for our loved ones, our population in general. Thank you.
Thank you, Dr. Dan. And it makes me wonder, Lisa, I'm not going to ask you to answer this question now, but it really makes me wonder who sits on these consent and capacity boards and how do they get there? That's a conversation I really want to have. I think we have to find a way to educate and equip the consent and capacity boards, because doctors are sitting there frustrated and they have to make, I know some doctors have to make decisions as, I'm not going to win this case because I know how the consent and capacity board thinks, but they know that that patient needs to be in hospital. So we know, and I think it's important for loved ones to know that sometimes our doctors' hands are actually tied because of how the system is set up. Jackie, any closing remarks from you?
My biggest pet peeve is when people start discussing the people that do not have any lived experience, whether it's caretaker or know of anybody, is you can't help anyone that doesn't want to help themselves. I feel like slapping people because they really don't understand that these ill people do not have capacity to understand they're not well. So how can they make a decision to get well? And we need to get that across to people, that they don't know they're ill. They don't understand they're ill. So we need to solve that problem. We need to get them help so they have insight. Luckily, there are some governments that are trying to make changes already in New York City and California. There's some big movements happening. Hopefully, the more and more we talk about it, and as Lisa said, the more and more we write our MPs and our officials and stop worrying about stigma and stop worrying about privacy, that it's the only way we're gonna be able to get change. So,
Jackie, that was so good. We need caregiver school. We need a caregiver school where we can go and you said it. You can't help someone who doesn't want to help themselves. How many times we have heard that? But Dr. Dan gave you the answer today. My loved one has a lack of insight because their brain is not, really receiving the information the way that you receive it.
Yeah, I think schizophrenia needs a whole new section in the Mental Health Act, and psychosis, this whole illness, needs to be taken away from the other mental health illnesses because it is different.
Yeah.
But when we get into bipolar, where it's a new thing, and even though you say that, it's harder for somebody with bipolar to have insight than someone with schizophrenia. That's a big challenge. Yes,
I was going to make that comment earlier today. The Healthcare and Consent Act says, I think Lisa can say better than I can, but capacity is presumed capacity. There's this concept that most of us should be presumably capable. However, the data is clear in schizophrenia. It's actually the opposite. Most people with schizophrenia are more often incapable, lack insight. So how can you presume they are capable? So as you said, Jackie, I like what you said. It might be different for schizophrenia. In fact, in practice, it is.
Mm-hmm.
So the presumed capacity. So I think we answered an earlier question. This is one of the things that needs to change in the Mental Health Care Act. This presumed capacity definition, or the way that they approach that, the fact that somebody is presumed to have capacity, even when there is no capacity at all.
Yeah.
Iris, I don't know what you're going to do with all this information, because you probably have conversations for the next year.
Well, I think we should give some homework to Dr. Dan. Come up with a better screening mechanism as to how people are determined to be capable or incapable. And I'm sure this is going to be a groundswell because the baby boomers are aging. And it's, you can't have a different law for one diagnosis versus the other. When they are presumed capable, just probe a little bit. Why? How? What do you mean by that? So that we get to the bottom of it, and don't skip over that first step much too quickly, because capacity does come before consent. And we're so, want to get on with, do they really understand they're going to consent? They're going to check the box and sign the paper. Are they really capable of signing that paper or weighing options? And the main option is, without any medicine, what's going to happen? People aren't getting better by themselves. People aren't going to get better without treatment. So, we have these experts here. The science is really progressing. And the time is ripe right now. We are not asking for any funds. We're not a charity. We're not asking you for any donations. Mothers for Mental Health Care Reform is just trying to get the messages out there. And we're actively looking for people to partner with, organizations to partner with, and do similar things like this one. And hopefully we will be able to leverage this meeting that we've had today and bring it to the attention of some other people who have even bigger microphones. Thank you so much, Nicole. You have an amazing website of your own. We've been fans of yours for a few years, and we do appreciate the volunteer work that you do. You're very capable, and we appreciate a lighthearted tone because it's important that we have to smile together and, energize one another. And I do appreciate that very much.
So I just wanted to thank everybody for being here today. And yeah, I think it's so important that we all got together on this panel because, every individual has their own special knowledge and experience. And it's only that together we can support the person as best we can. And I want you all to, I hope you come away from this with some hope, with some faith that things can get better. And I just wanted to say too, it's important, as a caregiver to take care of yourself as well. It's important to take care of yourself so you can be your best for your loved one, right? And I'm sure you've all heard this one, but the oxygen mask coming down in the airplane, which is pretty relevant because, it recently I saw in the news that plane blew out and oxygen mask came down. But if you haven't heard of the analogy, the oxygen mask, if you're there with a loved one that's not able to put on the mask themselves, put yours on first and then put on theirs. So make sure you take care of yourself. All the best. Be well. Have a good 2024. Thanks.
Jesse, you summed up the conversation well, and you left us with a message of hope and of truth and of compassion. And before I hand it back over to Iris, I just want to thank Lisa and Dr. Dan and Jackie and you, Jesse, for, taking me and being with me on this curated conversation. And I am going to turn it over to you because we had a really good think tank meeting today as well, as to how as we can advocate for our loved ones better so that they can be the best selves that they are in this season of their lives. Iris, over to you.
Thanks again, everyone. Let's stay in touch. Tell your friends. Send us an email, and hopefully we can work together on make some changes happen. Join the movement for improvement.